Thank you for this amazing lecture, Professor Sean. I would like to point out something to you for a moment. If you open the app, under the section More, you will find blood purification. And that PDF issue of blood purification, you will find Dr. Sean's elegantly written paper on what he just talked to us today. Now it is my pleasure to introduce our second speaker, Dr. Ananth Karumanchi. Dr. Karumanchi is a Medallion Chair in Vascular Biology and is the Director of Renovascular Research in the Department of Medicine at Cedars-Sinai Medical Center here in Los Angeles. Dr. Karumanchi also has a secondary appointment as a professor in medicine at Harvard Medical School in Boston. And Dr. Karumanchi will talk to us today about renal disease in pregnancy. Thank you, Dr. Karumanchi. Right is the green one, and yeah, to the left.
Okay. I want to thank the organizers for inviting me. I'm giving this talk in lieu of Professor Ravi Thadani, who was supposed to give this talk, and he couldn't make it. So today, we'll do a sort of summary of what's known about pregnancy, renal diseases in pregnancy. Mostly it'll be a clinical talk with some aspects of research towards the end. Particularly my area of work is in this very common pregnancy complication called preeclampsia, where we've seen a lot of advances in the last decade. So the reason pregnancy is interesting, it's really, you're talking about an extra an organ, that in this case the placenta and the fetus, and because of that there's a tremendous amount of increase in blood volume. And the placenta is an endocrine organ. It sort of crosstalks with a lot of the, by secreting hormones, it crosstalks with a lot of the maternal organs like the heart, the kidney, et cetera. So I think from a physiology standpoint, studying pregnancy can help us understand a lot of cardiovascular disease, kidney disease, as well as immune mechanisms, et cetera. So these are some of the physiological changes that occurs in normal pregnancy. You see a physiological hydronephrosis, and this is probably due to very high levels of progesterone, which tends to be a relaxant of smooth muscles. There's also the renal kidney size is also a little bit higher on ultrasound, perhaps by 1 to 2 centimeters. And there's also, because the GFR goes up, there's a slight increase in the physiological proteinuria. So typically, in a non-pregnant state, you would think there's 150 milligrams of protein in 24 hours. In this case, it's sort of more closer to 300 milligrams per, over a day or so. And because the GFR goes up, the creatinine goes down, and this is particularly important because many normal pregnant patients, a creatinine is around 0.5, 0.6 or so. So a creatinine of 1 or 1.1 could represent severe renal dysfunction and might be acute renal failure. So again, most of the changes there's also lots of acid-base changes. A lot of that is thought to be, again, related to progesterone, so you can get a you can get a physiological sort of respiratory alkalosis. The other thing I would say from a renal standpoint that you can often see in a renal consult is sometimes the placenta secretes an enzyme that degrades vasopressins. It's called vasopressinase. It's a leucine aminopeptidase that's made by the placenta. And you will often get called for consults for diabetes insipidus during pregnancy. And it's important to know that in pregnancy, serum sodium falls by about 4 to 5 points. And so even a serum sodium of 142, 44, 144 might represent early sort of diabetes insipidus. The major sort of changes that accounts for the blood volume increase is there's a physiological upregulation of the renin-angiotensin-aldosterone pathway, and this is significantly upregulated. And there's been many, many classic studies, and this is a paper by Chris Bayliss, who's a renal physiologist who did this work. And what's important to know is that this physiological increase in renin-angiotensin system goes throughout sort of pregnancy, But interestingly, in patients who subsequently develop preeclampsia, their renin-angiotensin-aldo system is suppressed. So the hypertension that you see in preeclampsia is not due to a renin-angiotensin pathway. In fact, it's a suppressant. And we'll talk about the mechanisms of how you get hypertension in preeclampsia. The other points to remember is that in pregnancy, really none of these formulas to calculate glomerular filtration really works. Because the GFR goes up, and as people know, the MDRD formulas, for example, don't work very well when above a creatinine clearance, let's say greater than 60. So I think then we've done some work with folks at the Brigham looking at cystatin C. Again, it's not as good as inulin clearance. I think so far I would say the gold standard today is still, if you really want to accurately measure GFR, is to do a 24-hour creatinine clearance. The obstetricians have almost always relied on a 24-hour urine protein to make a diagnosis of preeclampsia or other complications of pregnancy, but I think it's clear that it can be replaced with protein creatinine ratios, which works quite well. And there's been many, many studies comparing protein creatinine ratios, and typically we use a ratio about 0.3, for new onset proteinuria, particularly as you think about making a diagnosis of preeclampsia. So what are some of the things as a nephrologist we need to think about in pregnancy? The major changes are the hypertensive complications of pregnancy. So you can have patients who present with chronic hypertension who get pregnant. So you might be seeing those patients. Then there's another disease called transient hypertension, which, if it's sustained, it's often referred to as gestational hypertension. And so this is essentially a mixed bag of a number of hypertensive disorders. Some of these patients, go on to get essential hypertension later on. Sometimes gestational hypertension can be a harbinger of the more serious hypertensive complication, namely preeclampsia. And so this is, you often, when you have new onset gestational hypertension, you're thinking about preeclampsia, but many of those patients may not get it. But when you follow them long term, there's a very high incidence of essential hypertension in that population. You can have superimposed preeclampsia in the chronic hypertensive patients, and that's important to diagnose because preeclampsia is associated with significant morbidity and mortality, and so it's important to sort of make the correct diagnosis, and we'll talk about how that can be made. And of course, preeclampsia, this is the major sort of hypertensive complication that occurs in pregnant women with new onset hypertension and new onset proteinuria. So even though the incidence of preeclampsia typically in a pregnant woman can be as high as 4 to 5%, the reason that we're interested in some risk factors is particular risk factors like chronic hypertension, for example, has a significantly increased risk of getting superimposed preeclampsia. And in this case, it's about, typically the incidence could be 5% in patients with chronic hypertension. Perhaps the incidence could be as 10 to 15%. But one of the things that it reflects of all the various risk factors among the hypertensive patients, if you have a uncontrolled hypertension with diastolics greater than 100, that it particularly increases the risk of developing superimposed preeclampsia. So as a result, I think most nephrologists, obstetricians, and hypertensive specialists would recommend sort of controlling the blood pressure, throughout pregnancy to essentially to lower than 100 at least minimum of diastolic blood pressure to prevent preeclampsia. Of course, hypertension per se, can be managed. We have a lot of wonderful medications, but it's really that if you have the combination of hypertension and proteinuria, because that's the sort of the explosive disease, that's a vascular disease that can explode to the brain, other areas, et cetera, where most of the complications occur. And this is just a three-dimensional plot looking at fetal mortality, and you can see that the highest level of fetal mortality occurs in patients who have the highest level of blood pressure and the highest level of proteinuria. If we know that hypertension is bad throughout pregnancy, has that been tested in a clinical trial? And so this is probably one of the largest clinical trials done in this space. It was published in the New England Journal many years ago. It's called the CHIPS trial, where they took patients who have any hypertensive disorder pregnancy, either chronic hypertension or gestational hypertension, essentially asked if we control to the usual levels of blood pressure versus significantly tighter control of blood pressure, what would be the difference. And interestingly, essentially what this showed, you can see that the only thing that really the trial showed is that the tight control of hypertension prevented the development of severe hypertension. But really, when you look at the hard endpoints, fetal or even maternal preeclampsia, there was no sort of difference. So people might ask, like, if that's the case, do we really why should we insist on tight control? And the reason I would say is that the severe hypertension by itself in these hypertensive disorders, particularly after 34 weeks or so, is an indication for delivery. So as you can think about it, that if you can prevent severe hypertension, by treating patients aggressively, perhaps you can avoid iatrogenic delivery. So even though this trial doesn't really tell you that it protects you from preeclampsia, there is a tendency that if you treat patients aggressively, manage the blood pressures to relatively lower levels, you might avoid delivery, because right now the obstetricians are programmed to deliver somebody at 160 systolic. So there's a number of antihypertensives that are used. The date for which we have most data is methyl-dopa. That's the drug that was discovered in the 60s and or extensively used in the 60s and 70s, for which we have a lot of data. We don't particularly use that. I think the most common drugs used in this country are labetalol or nifedipine. And as a second line, if you need additional drugs, you can use hydralazine. The one thing to remember is that not to use ACE inhibitors or ARBs, primarily because these drugs cross into the fetus, and there's been quite a bit of data, particularly when used in third trimester or late second and early third trimester when the kidneys are developing. It can affect fetal kidney development, and so that's a drug that needs to be avoided during pregnancy. There's obviously, as a nephrologist, you will get to see a lot of glomerular diseases during pregnancy, and many times, you have to, diagnose those accurately and not, confuse them with preeclampsia, because many of these glomerular diseases can be managed throughout pregnancy with existing medications, and so some of the diseases that are often seen here are listed here. I'd say the most common things that we see are mostly diabetes, but essentially I've seen them all, and I think it's important to know that it's important to make the correct diagnosis. And many of these patients with diabetes or lupus, et cetera, can be managed. Their pregnancies can be carried forward. So it's important to accurately diagnose the condition. And sometimes you might need a renal biopsy to sort of really make the call. So what do you do in patients with chronic kidney disease, who are pregnant? And I think it's, this is the data from Hazlett at Yale many years ago, published in the New England Journal, and it's a good way to think about this. So if you have a patient with chronic kidney disease, shows up to your clinic, if your creatinine is greater than 1.4, I think you could basically say roughly about half of those patients, if they, throughout pregnancy, there won't be any significant change, but about a quarter of the patients would have significant decreases in renal function, either during pregnancy, and the other quarter would have significant, decreases immediately postpartum. And so it gives you a sense that, if you get pregnant, at least half of the patients will have further worsening of the renal disease, and so it's something that you need to be aware. There's also, this is the data from John Davis, and again, not many, there's not a lot of data in this area, so a lot of this comes from, individual physicians, and John Davison in the UK, this is his personal sort of data, and essentially, as you can see, that the more severe your CKDs when you're pregnant, you have more complications, more pregnancy complications, but also a more significant loss of further, renal function. So in general, I would say that it's wise to recommend someone whose creatinine is above 1.4 not to get pregnant, but that often, may not be the case. But at least here's some of the data to sort of say what are your chances of pregnancy complications or chances of, further worsening of renal disease. So I think we don't really know what about earlier CKD. So in stage 1, for example, CKD, is that also associated with further worsening of renal disease? And I think this is data from lots of different studies that my colleague put together in this slide, you can see even CKD1, there is increased risk of obstetric complications. And again, and the point here is that of course, when you have worse CKD, whether it's 3 to 5, you have more significant, obstetric complications. But even early CKD has, significantly increased preeclampsias, increased preterm delivery. But not all CKD is created equally. And so the point of the bottom graph is to show that particularly if you have diabetic, compared to, let's say, if you have IgA nephropathy or some other, glomerular nephritis, that you generally tend to do worse. So, for example, most diabetic patients do, especially if they're not uncontrolled diabetes, have diabetic CKD, they generally do worse, not only with regards to worsening of renal function, but also with poor, obstetric outcomes. And so in general, how do these patients get managed? I think you work very, very closely with obstetricians. I would say a lot of these so-called obstetric physicians now work with maternal fetal medicine specialists, especially people who have chronic kidney disease or some degree of chronic hypertension. It's probably best to sort of co-manage a clinic. And this is an article from Dr. Hradanovic from Toronto, describes about how in her clinic in Toronto, how this is, they manage. So a lot of the things like you start aspirin early in these high-risk patients, you give calcium for the milk production, you follow with, ultrasound scans, and you manage, blood pressure aggressively to try and keep blood pressure less than 140 over 90. But in general, I think a nephrologist managing with their obstetrician, is the way to sort of go in these patients who, really can get a lot of complications acutely. So what about AKI? It's clear that chronic kidney disease by itself, has worse obstetric outcomes. But what about history of, acute renal failure? So Jessica Tangren was a nephrology fellow at the time in Ravi Thadani's group, decided to ask this question. And really the question was really, you have many women who've had history of prior acute renal failure, and then their renal functions are normal. But if they get pregnant, what are their outcomes? And so this is a large sort of a study from the Mass General looking at roughly 100 patients who had history of prior AKI, but during pregnancy you can see that the creatinines were, compared to the controls, were more or less identical. And so you couldn't tell just looking at the laboratories values that these patients have had prior acute kidney injury. But what's very interesting is that these patients who've had history of prior kidney injury, they have more preeclampsia, for example. They have many of these obstetric complications. So the question is, why is that? And this is obviously a new finding, and so we've been quite interested in this observation. And I think it's probably that even if you've had acute renal failure in the past and you've recovered, even though the creatinine looks normal, your sort of renal reserve is gone. There's always some subtle renal damage. And so during normal pregnancy, your kidneys sort of hyperfiltrate, and you need that physiological sort of hyperfiltration, and you need increase in blood volume and plasma volume to have adequate perfusion of the placenta. And so what we're finding, for example, if you had a history of, if you create renal failure, for example, in a mouse, and then you make them pregnant, you can see that these animals have more placental insufficiency. So perhaps, so this is probably an important thing. It might be the reason why many, for example, preeclampsia may be quite common in the third world, where there's a lot of women who've had, prior AKIs and unrecognized, and then they got pregnant and they get a lot of these, pregnancy complications. Diabetes, as I said, is, they particularly don't do well if you have, diabetes without kidney disease. In general, you get 90% of those patients have good, they do well. But it's important to keep the hemoglobin A1Cs less than 7. In first trimester, hemoglobin A1C has been directly linked to all of the obstetric complications that you see in diabetic patients. But if you're diabetic and you have CKD, you do worse than CKD without diabetes, perhaps at least twofold, higher risk of preeclampsia. And the idea is, I don't think mechanistically people understand it. People think perhaps if you're diabetic, you already have underlying endothelial disease, and maybe your susceptibility to get preeclampsia, which is an endothelial disease, is perhaps enhanced. Lupus, you will see this. Lupus is a disease that's primarily seen in women, and so many of these young women, when they get pregnant, with lupus, you'll see, and you will have exacerbation. This is probably often a frequent consult, and sometimes it's very difficult to tell whether this is superimposed preeclampsia or lupus exacerbation. And the reason that's important is that if it's preeclampsia, you deliver them, but if it's lupus, you can treat them with steroids, and you can manage them and extend their pregnancies. And in terms of drugs, I think that you don't use some of the toxic ones like cyclophosphamide, but steroids and hydroxychloroquine are quite safe. And so this is something that nephrologists would often see. I would say that in 20 years of or 20 plus years of me sort of being in clinical nephrology, I would say that we probably might have biopsied 2 or 3 times in the past. I think that it's not it's not to be, if there's a need, you need to sort of biopsy, you just go ahead and do the biopsy. But I think that now we've developed fairly good markers, and we'll talk about some of the biomarkers of preeclampsia that we could essentially say that these markers could be used in lieu of the renal biopsy. But you always ask the question, the reason you do the renal biopsy is that will it alter management? So if you will alter management, for example, if it's lupus or diabetes that can be managed and not delivered, the biopsy might be indicated. AKI, you will see, you will get consulted for AKI when you're, in a pregnant patient, and this is roughly, depending on what stage in pregnancy, the types of AKI that you will get contacted. Again, there's nothing unique about AKI during pregnancy. You treat them like anything else. You might be called to dialyze patients, or if you see a patient with acute renal disease from HUS or TTP, which can often occur, you might actually have to plasmapheresis. I think this is a study that was from India that looked at some of the most common causes of AKI. Obviously, there are pregnancy-specific conditions like preeclampsia, for which the treatment is quite different, but there's also the standard sepsis and obstetric complications that's often seen in pregnant women. The TTP-HUS is probably, you'll see a lot, and this is a complication that can occur in pregnancy, but can also occur frequently in the postpartum period. This is particularly not exactly clear why the postpartum period. Perhaps many of them turn out to have antibodies against ADAMTS13, so you can measure those. Sometimes these are patients who have complement mutations. And these patients, it's important to recognize this from, for example, preeclampsia. And so preeclampsia, severe preeclampsia, typically presents with high blood pressure. Sometimes they have a lot of liver enzyme abnormalities. So many of these patients that you see won't have liver enzyme abnormalities. The hypertension typically not that common in HUS TTP. But what's interesting about this disease is that we now have some new ways of treating these patients. Eculizumab, which is a C5 inhibitor, can be used. So we just had a patient, I would say, it was 20 weeks pregnant, about 3 months ago here at Cedars-Sinai, who had severe HUS TTP, due to a circulating antibody against ADAMTS, and we were able to get eculizumab. And the reason eculizumab works is that has been used in pregnancy, is that there are the drug is approved by the FDA for the treatment of PNH, or paroxysmal nocturnal hemoglobinuria, and we now have data that many PNH patients, when they get pregnant, when they get eculizumab, the drug itself doesn't have any side effects or teratogenicity from a pregnancy standpoint. So I would say that if you think it's HUS, I think you should offer eculizumab. Pheresis can be used in these patients as well. What about dialysis? I think that this is, again, I don't have a lot of experience in this. I personally have sort of taken care of 2 patients, pregnant patients on dialysis over the years. And the big sort of take-home point is that unlike standard, ESRD patient on dialysis, you just have to do a lot more dialysis, and you intensify dialysis to maybe 4 or 5 treatments a week. Basically, you want to keep the BUNs quite low to avoid polyhydramnios, and that's anytime the BUN goes above 50, you have a lot of complications. I certainly personally have never done peritoneal dialysis in pregnant patients, but it can be done. The volumes are, people use lower volumes, for peritoneal dialysis. So what's the data for this? Where did this come from? So this is looking at the Australian. This is data from Australia and New Zealand, and essentially you see the pregnancy rates in dialysis patients is very low compared to, let's say, transplant patients, similar age groups, and the general population. And this is a very nice study, very recently published by Shaw et al., that essentially says that that looking at a large, Medicare database, the pregnancy rates is roughly about 17.8 per 1,000 patient years, but really that most of these women who get pregnant have, they generally don't have diabetes, as I mentioned. They generally have glomerular nephritis or nephrectomy related to malignancy and things like that. But for some, not clear reasons, people or Native Americans and Hispanics have more, pregnancy rates on dialysis compared to, let's say, whites. So these people have now, because this is such a rare event, you need to sort of combine data from around the world. And so this is a paper in NDT by Piccoli et al. That have looked at all the sort of the various studies that have looked at dialysis patients who are pregnant. And you can see the different centers, different studies have used different dialysis, total dose. And so this gives you a sense of, you see Canada, for example, uses a lot more dialysis than many of the other studies that are published here. And what came out of this sort of, large sort of review of the literature is that the prematurity is directly inversely correlated with the dialysis intensity. So the more intensive dialysis that you do, you have better outcomes. Your pregnancies tend to be closer to term. It's the same thing when you look at small babies. Again, the more intensive dialysis you do and keep your BUNs less than 50, you generally have a healthier sort of baby. So it's clear that at least from these data that if pregnant patients get or on hemodialysis, you intensify the treatment to keep the BUNs quite low. So now, this was a very interesting case report. It was published by Chris Chan from University of Toronto. So this was a patient who they had a very difficult time. Was an ESRD patient on standard dialysis. There was a very difficult time managing the blood pressure, and so this patient got switched to a more intensive dialysis. In this case, nocturnal hemodialysis, which was roughly 7-hour sessions for 7 nights a week. And what's very interesting, within starting this treatment from a standard dialysis, this woman essentially within a couple of weeks regained a normal menstrual cycles. So we know that patients who are ESRD patients are often infertile from hyperlactins and other sort of hormonal problems. But you can see just essentially normalizing the uremia, this patient got pregnant and essentially delivered a 3-gram infant at 38 weeks of pregnancy. So really, ever since this first case report appeared, folks in Canada, for example, do a lot more dialysis, and that center, particularly for women who want to get pregnant, end up sort of being a referral center. So primarily led by Chris Chan and Michelle Hadanovich. And so this is data from a few years looking at about 22 ESRD patients who are pregnant in Toronto, where they do this intense dialysis. And this data was compared with Susan Howe, who's sort of one of the legends of sort of obstetric nephrology in Chicago, and looking at her sort of database. You can see here that the live birth patients in Toronto, there was about 83% live births compared to, let's say, 50% in the US. And the big difference was obviously the number of the dialysis hours was about twice in Toronto. So that they were doing much more dialysis, more intensive dialysis. And the thing that one would be interested is, this very low birth weight infant. So these are the patients who end up staying in the NICUs for months and have lots of complications related to the low birth weight. And you can see there's a substantial decrease in the amount of very low birth weight infants, like 6% versus 29%. So really, the people in Canada have really led the efforts in this space, offering us, new ways of thinking about these pregnant women, who are on dialysis. That the idea of dialyzing them intensively, not only they can get pregnant, but once they are pregnant, intensive dialysis might help them get better outcomes. So this paper was published in JASN a number of years ago. Again, looking at live birth rate, you can see this is the data plotted in tertiles. The higher the hours of dialysis, the better outcome for the babies. Likewise, this is looking at birth weight or gestational age. There's clearly a trend that the third tertile that had the highest dialysis dose generally did better. They delivered at a later gestational age. They also, had bigger babies. So the key point is that in general, in women who ESRD patients, in general conception, there's a very low likelihood of conception. But if people are interested, I think intensifying dialysis might be a way to sort of get them from, to convert them from being infertile, and they can get pregnant. But if they are pregnant on dialysis, I do think it's quite clear that high dose of dialysis has a better outcome for the baby. This also, because dialysis per se is ESRD per se has a lot of sort of vascular problems. There's a lot more complications in these patients. So I do think that they need to be monitored, and I think the idea of sort of intensifying dialysis to help prevent these complications is warranted. But many of the things that we typically use in dialysis patients is substantially changed. So that there's physiological anemia in pregnancy. So sometimes, in the couple of patients that we've had in Boston, we had to give almost 2 to 3 times the EPO dose. You obviously give a lot more iron. And there's obviously there's less experience with PD, but in general, I think, as I said, that you do a lot more PD with smaller volumes. That's what's sort of written in the books. What about transplants? I think that many women are getting transplants. They want to get pregnant, so it's an ideal time. You want to do it when the allograft is stable. You want to obviously optimize the immunosuppression. And there's no question that transplant patients have higher complications, particularly preeclampsia, low birth weight, et cetera. I would say this is a sort of a summary from Susan Howe's sort of review. Essentially, in her practice, she uses, a year after transplant, the creatinine's got to be, quite low, ideally less than 1.3, and the patient should be adequately managed for blood pressure, no proteinuria, and should be converted to azathioprine, prednisone, and cyclosporin. And the reason here is that both CellCept and rapamycin can't be used because they're both associated with teratogenicity. So I think we go back to the good old-fashioned days of using Imuran instead of CellCept. So you use cyclosporin or tacrolimus, steroids, and Imuran. The other interesting thing that has come out more recently, this is data from Canada again, was initially these studies came out from Norway, where they have this huge sort of databases, the entire sort of medical records for the countries in a single sort of computer. So they can churn out these large data sets, insights from good epidemiological studies. It's quite clear now from many groups that if you have donated a kidney and you get pregnant, there appears to be perhaps a 2-fold increased incidence of preeclampsia. So whether that's and so this is people need to sort of counsel patients appropriately and make from an individual patient standpoint, they need to be aware of it. Exactly mechanistically, again, it might be related to the fact that if you have one kidney, you're already hyperfiltrating, and so you're not able to sort of further expand the plasma volume, blood volume, and it may not be able to perhaps provide the placenta with adequate perfusion? I don't think we know the answer, I think, but this can be experimentally tackled and perhaps, in animal models, et cetera. But at this point, I would say that, this data is quite clear. There's been a meta-analysis now, and it's quite clear from lots of different groups around the world that, people who have donated a kidney, there appears to be slightly higher incidence of gestational hypertension and preeclampsia. So this is an area where I think there's been a lot of basic science, understanding of exactly, over the last decade. Many of that work, we've done it ourselves in our lab, but many laboratories around the world have, worked in this space. This is, as one of my mentors, Frank Epstein, used to say, this is probably the most common glomerular disease in the world, except not too many sort of nephrologists who are working on this. So a number of years ago, I would say more than a decade ago, we were interested in this disease, primarily asking what factors come out of the placenta that causes the hypertension and proteinuria. There's obviously a lot of risk factors. We can talk about it. But many of these risk factors give insights, clues as to why, some patients have more preeclampsia, so for example, multiple gestation, if you have twins or triplets, you have maybe 2 to 3-fold, sort of more, preeclampsia. So I won't go into the details of the biology, except to simply say that using sort of a molecular profiling of the placentas from patients with preeclampsia, many years ago we identified specific molecules that are causal to the maternal syndrome. In other words, that cause hypertension and proteinuria. And one of these factors is a protein called soluble FLT1 that's sort of uniquely made by the placenta to regulate its normal angiogenesis. In patients who are particularly ischemic or have placental disease, this particular pathway is upregulated 2 to 3-fold. It's secreted in the bloodstream, and it causes the hypertension and proteinuria, and also some of the complications like HELLP syndrome and liver disease. So this is, obviously, it's sort of like having ANCA. Before you had ANCA, it was very difficult to know, how would you diagnose a post-immune glomerulonephritis. I think because we were able to identify this pathway, we now have these diagnostic tests. So this is, just like troponin or proBNP, you can actually, measure these. So these are assays offered on an automated platform by Roche. So this is soluble FLT and PLGF. And typically, how is this test currently being used? This is being used essentially to rule out preeclampsia. So if you have suspected preeclampsia, maybe a patient with lupus or diabetes, you can order this test. The test was negative, ratio less than 38. You can say with 99% certainty that you don't get preeclampsia in the next week, and maybe 97% that over the next 4 weeks. So this test is now approved in Europe and is approved in many parts of the world, Australia, Japan, etc. Is not yet approved here in the US, unfortunately, by the FDA. And so we're hopeful the next few years it'll be available. But if people have patients where in the clinics or in they're welcome to send their blood sample to us either in Boston or here in Los Angeles, and we're happy to sort of measure them. In fact, a couple of weeks ago, we had a call from Northwestern. We had a patient, at 20 weeks. They weren't sure that this was HUS-TTP or preeclampsia, and this was a patient that the bloods were sent to us, and we told them that the levels were very high. So I'm happy to sort of offer these tests until these become, widely sort of available. I think the utility of the test is largely in the preterm gestational window, primarily because as you can imagine, if you make the long call and you take a diabetic patient and deliver them thinking it's preeclampsia, you're left with a premature baby. So many times, knowing that this is not preeclampsia is important because you can extend their pregnancies, and you can see the fetal complications plummet as you get closer to term. So the idea is, how can we push pregnancy to closer to third term, 37 weeks or beyond? And so so even in the absence of a therapeutic intervention, availability of a reliable, specific diagnostic test helps you, particularly to avoid a lot of these iatrogenic, prematurity. There are a number of ways to tackle the number of ways to tackle this disease, and I think as nephrologists we all have to get aware of this, because I think there's going to be a nephrological therapy for this condition. So because it's very difficult to develop drugs in pregnancy pharmaceutical companies are not interested, primarily because most drugs cross the placenta into the fetus, and so addition of a drug has been a bit of a challenge. So the idea is, if this is a toxic factor, could you remove this? And again, the volume of distribution of this protein is pretty large, cannot remove with the standard sort of a plasmapheresis. So you have to have a specific absorption column that can selectively bind. So this is some early data that was done by my colleague, Dr. Tadani, in Germany, using this column called dextran sulfate. It bases, the idea would be that because soluble fluid is very positively charged, this column is very negatively charged, you can actually literally, like dialysis, you can freeze this patient and selectively remove a lot of these positively charged proteins. So this particular method is approved by the FDA here for the treatment of familial sort of homozygous hyperlipidemia. So it is available, not extensively used. But one of the things you can see here in this study, even a single treatment, for example, compared to controls, the contemporaneous controls, appears to sort of extend pregnancy by a week or longer. And so, obviously one needs to improve this, doing multiple treatments. But the other possibility is, because the clearance is still quite low using this device, we've now generated in the laboratory an antibody-based column. So you have an antibody to S-FLT, and that's attached to this column. So I think that those studies are now ongoing right now in the UK. And we'll probably hear about it next year from Dr. Tadani. And I'm pretty optimistic that this type of subtraction approaches that are very specific might be the way to go in these patients. And I think that so eventually I think nephrologists are going to get even more involved in taking care of these pregnant women. So this was the paper that summarizes some of this data that I shared with you. So I think these are some of the key references here. So I've sort of taken you, a big summary of some of the things that are going on in pregnancy, and some of these articles out there. Thank you very much.